welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So our next presenter is going to be Caleb Scrime, a PGY2 EM resident at the University of Chicago, Illinois, who will be presenting on the comparison of prophylactic and therapeutic doses of anticoagulation for acute chest syndrome and sickle cell disease, the TASC double-blind controlled randomized clinical trial.
Objectives for today, we're just going to review the trial's methods and outcomes, analyze some of the results, and then discuss results of the trial and potentially applying it to your patient population. So now into some background. So as we know, with acute chest syndrome or ACS, kind of three common causes of ACS, and they really all relate to inflammation and sickling. So pulmonary infection is a common cause, fat embolism from the bone marrow infarction, and then a pulmonary infarction. So as you can see in this picture to the right here, kind of like instead of a coagulation cascade, we have kind of an ACS cascade. And the big thing I want you guys to focus on going forward is this BCAM1 expression, because it plays a central role in kind of the pathophys of everything that goes on with acute chest. And it will kind of relate to a slide I have coming up later, because this causes kind of like a adhesion expression with the BCAM1, and that can cause inflammation and vaso-occlusion and lung injury as well. So moving on from that, so the reason kind of for this study really is we're kind of trying to achieve a faster rate of ACS resolution. So as we know, with this higher risk, patients are at higher risk of developing pulmonary thrombosis. And to the right here as well, with CT, they're not always, sickle cell patients aren't really best used to use CTPA. There's actually been a study that I referenced here below that looked at CTPA and outcomes, and that in the small vessels and arterioles, ACS patients really aren't always seen to have the pulmonary embolism that would be seen in a normal patient because of kind of the pathophys behind what's causing the actual pulmonary infarction or the thrombosis. And then, as you know, it's a vascular dysfunction as well. So if left untreated, this can lead to obstruction later on in the visit if we aren't, I guess, staying ahead of it or getting on top of it early on in the presentation of the disease state. So yeah, goals of the trial really are confirm if therapeutic coagulation compared to a prophylactic approach will improve outcomes for sickle cell patients presenting with acute chest syndrome. So quickly, I just want to talk about tenzapiran, since this was a French study. It's very similar to enoxaparin. The dosing is just a little different, as you can see here below. And it has similar kind of pharmacokinetics as we'd see with a enoxaparin dose. But I just wanted a brief little summary for everyone to see so that you're aware of kind of the drug itself. As far as like a comparison of the two, just so we know if when we're applying this to our patient population going forward, there wasn't a lot of studies comparing the two. I found an NSTEMI study that looked at kind of reducing the incidence. It showed reduced incidence of MI or angina or death in the enoxaparin group compared to tenzapiran group. And then in a study in cancer patients for VTE, there was no difference in recurrence between the enoxaparin and tenzapiran group. So as far as we know, fairly similar efficacy and fairly similar pharmacokinetics that are between the two drugs. So these can be applied to a US population where tenzapiran is not available to us. So this kind of brings me into where I discussed earlier with the BCAM1. So this study referenced below here actually looked at enoxaparin and was shown to decrease plasma TNF alpha. There's also an increase in hepatic lipase activity. And as we know, kind of with some studies that we've seen with heparin, that heparin kind of has a similar anti-inflammatory / like lipolysis effects. So enoxaparin isn't as strong of these effects with the anti-inflammatory and lipolysis effects as heparin, but in these patients with ACS still can be beneficial with this inflammatory state, because when we reduce the TNF alpha effects, this actually has a direct effect on BCAM1 and down-regulating that as well. So kind of directly related to that inflammation process and adhesion that is causing this acute chest syndrome activity and pathophys essentially. Now we're just going to jump into the trial and some of the methods. So primary safety outcome was one of the big things. I'll just briefly touch on this. The real difference here that they did not include was the transfusion, obviously, because these patients, if needed a transfusion, were offered one before or during the trial. But they did account for bleeding as a decrease in hemoglobin and then any fatal bleeding that did occur in any vital organs. So that was the primary safety outcome. As far as the study design and population, it was a double-blind randomized trial in enrolled patients with history of sickle cell disease presenting to 12 different French hospitals from December of 2016 to February 2nd, 2021. They did include all different types of genotypes of sickle cell disease, but I'll discuss later that the SC, SB0, and SB positive were not really represented in this trial. It was mostly SS genotypes. But the way they defined ACS was any new parenchymal pulmonary infiltrate in at least one segment of the chest X-ray or CT with a respiratory symptom or a pulmonary auscultation sound. And then they randomized them in blocks of 4 based on the patient's PaO2 or FiO2 ratio of less than 300. And there's some of the exclusion criteria. So body weight was a big one, obese or underweight, any creatinine clearance less than 60 due to dosing issues with tenedipiran. And then if they were on a therapeutic indication for anticoagulation at home, and if a blood transfusion was deemed a risk for the patient during the hospital stay. So as far as some baseline characteristics for the patients, the one I really want to point out, and I just pulled this from the trial just so you guys are able to see everything. The one thing that was frustrating about this trial was that race and ethnicity were not collected as per French law, part of their study, but 58% of the patients were men and 58% of the patients were men, 42% of the patients were women, and the average mean age is about 29.9 years. But as you can see here, the real thing that I want to point out is that, and in applying this to your patient population, it was only about 22% had a documented infection at the time. So really it was more patients presenting with a vaso-occlusive crisis that turned into a acute chest syndrome at the time. There is some representation of infection, but not quite as much. Otherwise, as you can see, we have a good balance of between the two groups of the prophylactic and the therapeutic. And there was no major differences that I was able to point out as well between the two groups. As far as trial interventions, there was either the prophylactic tinzaparin group or the therapeutic tinzaparin group. The big thing to point out with this is that for the prophylactic dosing, this isn't the weight-based dosing, this is the lower end of the dosing. So that could have some effect on the outcomes if patients weren't getting the adequate weight-based dosing that is recommended in the package insert. But as far as the therapeutic, that is recommended. And they were on it for 7 days or until hospital discharge, whatever was, if the hospital discharge was sooner than 7 days. So going now into our primary and secondary outcomes, the main reasons. So what they looked at really was time to ACS resolution. And this was defined as a time from randomization, so into the trial, and an improvement of 4 symptoms with fever, chest pain, dyspnea, and hypoxemia. And if patients did not have hypoxemia at baseline, that resolution was not included in the needing all 4 symptoms improved. And then as far as secondary outcomes, there really was only non-major bleeding, transfusion, mechanical ventilation if needed, catecholamine infusion, cumulative dose of parental opioids, which we'll talk about later. And then at 6 months was just readmission rates, thrombotic events, and all-cause death. As far as statistical analysis, they used a Kaplan-Meier plot to assess resolution time and for up to 15 days or until hospital discharge. As far as their regression analysis, they used a Cox regression analysis, which stratified with hypoxemia as like one of the variables included within the trial. And a hazard ratio less than 1 indicates a shorter time for your therapeutic dose anticoagulation, and a hazard ratio greater than 1 would indicate a longer time for your therapeutic dose, just for your reference. And as far as power for this study, there was no kind of baseline of what to expect because there's no real trials prior to this of looking at acute chest syndrome and therapeutic coagulation, but they wanted a goal of about 86 patients in each group. They were able to get 86 in the therapeutic, but only 82 in the prophylactic group. So now we'll jump into results. So as far as our Cox model regression, the hazard ratio was reported at 0.71, which was significant for a faster time to resolution of the acute chest syndrome. As far as in days and representing the time in days, this was also found to be significant. It was about 6.1 days with plus or minus 0.5 in the prophylactic group versus 4.1 plus or minus 0.4, which is about a 1.3 day difference, which can be significant for a hospital stay, and it was found to be statistically significant based on their statistical analysis of the primary outcome. But as far as rate of ACS resolution, this was found to be fairly similar, a little higher in the therapeutic group, but nothing that was reported as significant. So basically what we can see here is that we had a faster resolution time, but there was no difference in the actual patient being, the acute chest syndrome being resolved. And also as a primary safety outcome that I mentioned earlier, there was no major bleeding that was defined in either group as for prophylactic and therapeutic. As far as secondary outcomes, the one that was most interesting to me reported out cumulative dose of opioids. As you can see here, in the prophylactic group, it was about 219 milligrams versus 124 milligrams in the therapeutic group. And this appears significant to me and is reported as significant as well. And it's also an interesting outcome because it makes you wonder, with that inflammatory state that the transparent has at the higher dosing, are we actually able to apply this even to a different population of sickle cell patients to help eventually reduce opioid needs in those patients as well. As far as their chest pain score, there really was no statistical significance, and the scores were fairly similar of 1.6 versus 1.07 prophylactic versus therapeutic. And yeah, that's really much, but it's kind of a subjective score, or so hard to really say. But I think looking at the opioid, you can kind of compare this to the scoring of the chest pain score as a good comparison. And then as far as time to hospital discharge, although the ACS was resolved, there wasn't really a huge difference in kind of your mean discharge time, which is kind of interesting to me, that the acute chest syndrome had resolved, but the patient wasn't actually discharged. So as I mentioned, kind of going forward, is that like the parental opioids was really the most significant secondary outcome, and that we saw the difference between the two groups. This wasn't really represented in our chest pain score, I thought was interesting, but also, and there was no real difference in the length of hospital stay. So kind of looking at the trial a little deeper to understand why there was no change in discharge, but there was for some reason, a perceived outcome of a shorter ACS resolution would be something to investigate in this trial. But as you can see, as I mentioned, the cumulative dose of opioids is really the one that stood out to me. And then as far as 6 months, there was no differences really seen, so I didn't discuss these too much, as you guys all saw in the trial. And then of the patients in the prophylactic group, 2 patients developed a PE, one developed a PE, one developed a DVT while admitted into the trial. And no deaths were reported during hospital stay in that 6 months as suspected. So as far as like a conclusion, the study shows a faster time to ACS resolution, but not a faster time to discharge. To me, that can be kind of counterintuitive, because I guess it would depend too, is like who's handling the discharge and how that was all going about during the trial. But with the subjective, like 4 things that included a time to faster ACS resolution, there was a reported outcome that this was a faster time. There was also a reduction in the opioid usage during hospital admission, which I think is the biggest thing that I got from this trial, was that we're reducing the amount of opioids that are needed to help treat this kind of vaso-occlusive crisis / acute chest syndrome. And then some kind of like things I wanted to point out that I mentioned earlier as well was that this really only applies to our patients with the SS genotype. This was the population that was more represented in this trial. Out of the group in the therapeutic, it was 77 out of the 86 patients, versus out of the prophylactic group, it was 72 out of the 82 patients. So there's really majority of the study was this SS genotype. As we know too, the study does not apply to overweight or CKD patients, just because those are obviously not represented in the study. But typically your sickle cell patient would not be an overweight patient. And then as far as changes in mortality, there was really no difference, obviously, that was seen. Kind of a weird outcome to assess as well. And then race was not defined in the study, which can be a barrier to applying it to your patient population as well. So kind of in clinical practice, like I mentioned as I was talking, this should be applied to patients with an SS genotype because of the high representation and normal renal function with a normal body weight. And then has the potential to shorten hospital stays and increase time to ACS resolution, but that would further need to be studied, and maybe our time of ACS resolution did not directly correlate with our time to discharge as well. So as far as future studies in this area, I think would be represented well would be, again, the use of enoxaparin. That'd be a good study going forward. Maybe the inclusion of underweight patients. So those can be sometimes seen in our sickle cell populations as well. And also patients with a poor renal function or AKI, maybe considering heparin in those patients would be another study that I would look at. As I mentioned too, I'd also like to see other genotypes that were not represented in this study included in future studies. And then as the opioid requirement that I discussed as well, looking at like if vaso-occlusive crisis would play a role in using low molecular weight heparins as well. Eventually as well, if the effect of DOACs, is it the anticoagulation effect, or is it the anti-inflammatory effects that we're actually getting a benefit from in these populations? So looking at maybe possibly DOACs versus heparin or low molecular heparins could be kind of like another future comparison trial after we look more into like a vaso-occlusive crisis or the benefit of enoxaparin with other future studies. So with that, I'll wrap up. Is there any questions that I can answer at this time?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.